Hello, everybody again. I hope that we're trying to get ready for the second case. The surgeon will be Dr. Jose, and we're waiting to be connected with the operating theater.
Je préfère que ce soit direct.
Hello. We're live. Do you hear me?
Yes, we can hear you.
Okay.
I wish you can.
So can you please present the case to us? Whenever you are ready.
Hello, everybody.
Good morning, Jean-Baptiste.
Morning. How are you?
Fine, thank you. And could you present the case?
Yes.
To us? I mean, some baseline characteristics of the patients, and because today we have this is the second case with ThuLEP. So please.
Yes. So it's a 62 years old man who had a previous incision of the bladder neck, as you can see, and he has a recurrence, as always, after that kind of surgery. It's an 80-gram prostate, no complication, and I think he had a stone, a bladder stone before, and he had just a bladder lithotripsy before. And so the first problem we had was a small problem with the urethra, which is a little bit tightened. So I just do a light urethrotomy to put the Storz resectoscope, which is a 26 Storz resectoscope. It's quite good because it's very smooth, but the problem is the size. So with that, you're going to have a good irrigation, but the problem is to have a compliant urethra. So I think it's going to be okay. So I do the urethrotomy, and we will try to put the resectoscope inside the urethra. Thank you. Thank you. So let's have a look on that.
So what kind of instruments do you use?
So I use the Storz device. So I don't want to be traumatic with the urethra. It seems to be okay now. Okay. So I'm going to use the resectoscope. So as you can see, I use, as you will see, I use two wings to try to optimize the exposure of the plan. As you can see, if it fits well, okay, like this. So it was something I began when I began my activity and of enucleation, and I kept it. I have to. Just a second. Non, non, il faut que je mette. I have to connect the resectoscope well. Attends, c'est sur 0. Okay, I think it's going to be okay. Quelque chose qui déconne. Hein. Il faudrait qu'elle tienne, je sais pas. C'est peut-être la pièce. I just have to adapt the resectoscope. So we change one piece of the Storz system. Is it correct? We will see this in a minute. Yeah, it's better. Definitely. Okay, so let's check the anatomy. So first we're going to see the verruc. We're going to see the sphincter, which is quite long for this guy. Okay, I think that as probably Fernando told you, the endoscopic anatomy is very important in this. It's not endoscopic management, it's surgical endoscopic management. Okay, so we have to perfectly see what we have to do. So the sphincter, the upper part is here, and generally the stress urinary incontinence is due to a lesion of this upper part of the sphincter. As you can see, we see the verimontanum. Perhaps we're going to try to do an ejaculation sparing technique because I think it's possible, because he has not a very bulky apex, so I think it's going to be possible. What we see here is that slight hole. Generally, you can use this slight hole right here to see where is the correct plan, because generally it begins here. The plan can begin here, so it can help you a little bit to find the correct plane of enucleation. And then after we check the bladder neck, we see the previous incisions, and we will see during the dissection how we can manage it. And then after, check ureteral orifice, which are very far from the bladder neck, so no problem with that. I won't check it anymore during the surgery. So have you got some scissors? So I will present you the laser. So as I told you yesterday, it's a laser we developed with Quanta System and Rocamed. So it's a 200 watts laser of thulium, the second generation of thulium. Now we have the ThuLEP, but it was the second generation of thulium. So the settings are, it's a long pulse, 20 milliseconds, with a low frequency to try to increase the power we have in each pulse during the surgery. And with that, try to optimize the Moses effect we can have in the thulium, which is much lower than the one you have with the holmium. But we have some Moses effect. So it's a 200 watt laser, but if we combine the different settings, it will be 60 watts for each pulse. All right. So every pulse will have 200 watts, but if you combine it during the seconds, it will be 60 watts. So, okay. And so we check the laser and we check the settings to have some ability of the settings to adapt to enucleation, vapoenucleation, or vaporization, which is in continuous mode. What you have to know with the thulium, the more continuous you are, the more charring you are, and the more hemostatic you are. So that's the reason why we have two pedals, one for enucleation in pulse mode and one for coagulation in continuous mode, to have an optimization of the hemostasis during cauterization. So we're going to begin. So we're going to try to do an en-bloc technique. So as you can see, I begin under the right lobe. You see how hemostatic properties of the thulium are working. So I will check the verimontanum, and I try to not to coagulate it or damage it. And I will try to keep the 1 centimeter of tissue above the verimontanum, because the ejaculatory ducts are running right here. All right. So one of the problem of the surgery of TRP or enucleation, that it's possible here to cut the ejaculatory ducts here, or cut the muscle who supply the ejaculation. So what we're going to do at the beginning is to try to cut all the small fibers from the urethra to the adenoma. So I won't push blunt dissection until I cut all these small fibers. I try to approach a little bit the plan of dissection. And now it's marked. I will mark a little bit the upper part to try not to injure the sphincter. And I try to cut all these supporting tissue of the urethra to try to have more and more mobility of the apex. So slightly, gently, we're going to try to find the plane of enucleation, and it works. So, as I told you yesterday, I try to be the less traumatic, and so that's the reason why I try to reduce the blunt dissection of the prostate, not to tract on the tissue, not to damage the functional structures of anatomy. So you can see that there is an important difference between the pulse of the thulium and the pulse of the holmium. And you see the difference of Moses effect, but the difference of hemostatic effect too. So I think the adenoma is here. So I will try to disconnect it properly. So sometimes right lobe is easier, sometimes left lobe is easier. So if it's difficult on a right lobe, I will switch to the left. So I will try to see the volume of the adenoma. I will cut this small attachment from the sphincter to the adenoma. And you see, I will try to go very carefully. What I try to find is the correct plane, because if I have it, it will be possible to reach the top of the adenoma and detach the sphincter properly. So I try to turn a little bit my endoscope during the dissection to fit the volume of the prostate. So I will have more and more space, I hope, during the dissection. So what I will try to see now is the attachment of the sphincter and the arch of the sphincter on the adenoma. So I go carefully. It's, of course, the most difficult part of the surgery. It's the apex detachment. So my wings are quite useful to expose the plan. of dissection. So here it's very interesting. It's something I changed perhaps a few months ago, perhaps 1 or 2 years ago. What you have to see is capital. Here you have the adenoma, all right? And actually here you have the capsule. And during the exposition, you see, I tracked a little bit on the capsule, all right? So before I was working over there. Now, sorry. Now I'm working right here. You see the difference? Because when you expose your adenoma, you have to understand that you tracked a little bit the capsule. And if you track the capsule, it changes a little bit the plane. And if you shoot in the capsule, you're going to have some small damages of the capsule that make bleed and that make, I think, irritative symptom in the postoperative follow-up. So it's a real surgery. So there is exposition, there is traction on the structures, and you have to see that and apply that to the way you manage the shoot of the sphincter. So very important here to be close to the adenoma and detach the structure properly without any traumatism of the sphincter. I have to be quite concentrate right now. Okay. So as you can see, it's not exactly the same plan of holmium. I do holmium too. I'm working in 2 institutions, so one with the thulium, one with the Lumenis 100 watts. And I have to admit that it's not exactly the same plane of dissection. I think that you have to be closer to the adenoma during the thulium because it's very easy to disrupt the capsule during the dissection. Because as Fernando told you, it's a device to cut very well. So it's totally possible to do bladder tumors with that, to do upper urinary tract tumors with that, with an amazing result. And so it's a laser who cut and destroy a little bit. So you have to be very, very careful with that. And try to be very close to the adenoma to avoid any traumatism of the surgical capsule. Okay, so it's not so bad. So I will finish the detachment of the apex.
Could we have the microphone for Professor Gomez-Anderson?
Yeah. So now we are at the anterior part of the prostate. We can go properly with a quite good vision. And that's what is their instinct with the thulium too. Because of the properties of hemostasis, it's quite easy to have a very good view during the dissection. Okay, so I will check the apex. So we will see here the attachment of the sphincter on the adenoma. So I will prefer to be close to the adenoma at this part, preserving the sphincter perfectly well. So as you can see here, I detach it slowly and properly. It's definitely the most difficult part of the surgery. Okay. Okay, now it's detached. So I will do an unblock technique. So now we're going to preserve the verimontanum and the cismontanal urethra, as you can see, to try to spare ejaculatory ducts.
So, Jean-Baptiste, what is your success rate when you try to preserve ejaculation?
So, to be honest, there are plenty of techniques. What we know is that if I'm doing this, if I spare the upper part of the verimontanum, I will spare ejaculation for perhaps 50%, all right? What we can do after is to change a little bit the dissection, not to take the anatomical plan, but mark right here the adenoma and cut the anterior groove. And when I'm coming to the apex, just let all that stuff, all right? So if I let this, the apex, and I let this, I will be more than 75% of keeping antegrade ejaculation. But if you do that, you're going to have an obstruction at the apex. So your voiding result, I think, going to decrease. So that's the reason why it's quite difficult to be very sure that your results between the adenoma and the voiding result and the ejaculation result will be good. And so what I'm doing, when I have a patient who wants to keep his ejaculation, generally it's a young patient, all right? So generally the prostate is not so big. So when the prostate is quite mild or small, it's quite easy to perform this kind of technique. And I perform a fibroscopy before to see the shape of the apex. If there is an obstructive apex, I say to the patient, it's not possible to guarantee an ejaculation sparing with a good voiding result. So, but it works, huh? If you take the apex, if you keep the apex and you keep the verimontanum and the cismontanal region, you're gonna keep ejaculation plenty of times. So it's important to cut, as I told you, all the supporting tissue around the apex before mobilize it with the endoscope, not to be traumatic. The plan is a little bit...
We can see that the quality of hemostasis is standing, but at the same time, it's easy to see that the effect of dissection of the plane is not as it was.
Yeah, it's a little bit. It's more difficult with the thulium for sure, because the mechanical effect of the bubble, you don't have it. So
what is the expected PSA in your patients? What do you expect the PSA to be post-op?
The PSA drop,
yes,
honestly, is really good, more than 80%. I think there is no big difference between holmium laser and thulium laser on this. If you do a real anatomic dissection of the plan, you're going to have the same result for the PSA drop. And it's very interesting. Enucleation for that is very interesting, because if you want to be sure that there is, if you have a PSA more than 2 nanogram per milliliter after this surgery, you can be almost sure that there is a prostate cancer after the enucleation, because generally the PSA drop is very important after enucleation. And what I have to say too, which is very interesting with all the enucleation technique, is that you are sure of your voiding results. So if you have some problems with voiding problems after the surgery, you can be sure that there is no residual restriction. and you can manage an overactive bladder or something. So I will do a little bit of mechanical dissection because it's not opening well with the laser. So I've got a small module right here.
Sorry, in the cases that you don't have a good plan, is it preferable to continue the operation in an even not optimal plane, or you have to insist to find the correct plane?
Excuse me, I didn't understand the question.
When you don't have a good plane, what do you prefer to do?
Yeah, I understand. Okay, yes, it's important to keep the good plan, but sometimes if you have a landmark between two planes, it's possible to cut a little bit in the adenoma. But generally, yes, if you can keep the good plan, it's better to have it, of course, because you're going to remove all the prostatic adenomatous tissue with that technique. Yes, of course, I would try to have the good plan, but as I told you, it's not always very easy with the thulium. I think it's anatomical enucleation, but the plane is not always the same that you have in the thulium. With the holmium, sorry. I think that the choroid plane is right here. I have to be a little bit concentrated for detachments of the sphincter.
The problem of thulium lasers has been that surgeons who use them where there's a lot of papers of creation that are very difficult to interpret, and degrees of removal of BPH. So do an anatomically guided, when you use these pushes to find that you are in the right plane to do an anatomical enucleation, then it's more similar to HoLEP in the sense that you try to do a proper anatomical, and this is the difference between ThuLEP and ThuLEP. That intentionality to go all the way to the proper plane. The thulium pulse, thulium laser can do an anatomical job, a perfect job. A lot of experience.
Okay, I will cut the urethra at the top of the apex and try to reach the right plane of dissection. Water, okay, it's okay. Okay, so
if I can add a small remark comparing holmium with thulium, is that the holmium preserve the quality, the visual quality of the tissue, so it's much more easier to follow the correct plane once you're found it. In this case, the charring that is secondary to the action of thulium laser transform the nucleation as Fernando has already said, in an inventing plane. I think you are supposed to go on the right plane, but the anatomical reference that you maintain with holmium laser are now more present here.
So, is there any experience in the results if you don't have the correct plane and you just invent it? Do you have different results?
Basically, when you perform enucleation, sometimes you are compelled to invent the plane because, for instance, there could be inflammatory processes, previous prostatic biopsies that can distort the plane. But it's just a matter, as Fernando said, of experience. You go on the according to your experience where the plane is supposed to be. But for a beginner, it could be very difficult, very disorienting, very not so easy to follow.
All the bulking techniques have the potential to improve, and we have seen that for resections, excellent results, functional results at the beginning. The problem with leaving change, the prostate will collapse, and then remaining BPH tissue will grow. So, what we doing a channel in the center of the prostate, patients would have extremely good flows. It was very minimally invasive. We didn't leave a catheter, but of course, with time, this didn't last too much. So I think when you invent a plane, the patient will do well, but similarly to a TURP, in the sense that you debulked the center of the prostate.
1200, puis je monte
And functionally, they will do well, but it won't last over time, I think.
So I think we do a good job now. As you can see, probably the anatomical plan is not exactly the same that the one we have in Holmium, but I think it's quite good. As you can see, there is no damage of the capsule. Of course, you always have some small nodules who makes hernia in the capsule, which are very, very difficult to release. And generally, I have to say that if they are small, I won't remove them. And it's, of course, probably a risk of recurrence, but it's quite small. As you can see, we will remove, I think, more than 90% of the adenoma, even with the thulium.
The surgeon must have the heart of the lion, the eyes of the hawk, and the hands of the lady. And you have ladies' hands, You're very, very careful and very, very gentle, and that's very beautiful. I think you have the breath of the lion more than after yesterday.
So now we're gonna try to dissect the anterior part and find the bladder neck properly. So it's with the thulium, it's possible not to touch. So if you are not touching the tissue, right, you're gonna have a site of dissection. But if you go in the tissue like this, you're gonna cut. So you have to manage the distance of your tip of the fiber during all the surgery. And sometimes you have to be very close to the tissue, and sometimes you have to be far, just not to perforate or to go too deep with the laser. So this is the anterolateral part.
Impression about is that the thulium laser and the thulium fiber laser have even better hemostasis than holmium, even with Moses. But of course, they have the disadvantage of not opening up the plane so much.
Yeah.
What do you think it's to learn? I mean, would you learn with a holmium, or can you safely learn with a thulium laser? What do you advise people?
Yeah, I think probably if you begin with enucleation first, holmium will be easier. I think that. But I think that if you use first vaporization of the prostate, ThuLEP and after ThuLEP, it will be definitely possible, because if you have a problem during your ThuLEP, it will be possible to switch to a ThuVEP, and you will finish your procedure without any big problem with your patient. So I think it's possible to begin with a ThuLEP. It's probably for the dissection technique a little bit more difficult, but I think that it's the same with the GreenLEP. The GreenLEP is a continuous wave, a continuous emission, and during a continuous emission, you have no help to open the plan. But what you have to know is that in Saint-Augustin, we do HoLEP, and we coagulate all the patients after the surgery. So generally, we don't do like Fernando, a coagulation with the holmium. We generally coagulate with the electric ball, and it's not the case with the thulium. So perhaps with the next generation, or the Moses 2.0, or the virtual basket, the results of coagulation for the holmium are better. But it was not the case with our Lumenis 100 watt, and it's a problem. It's an intellectual problem, I think, to have to change energy to make the coagulation, to make the patient be discharged at day 1, because generally before coagulation, our patient with holmium were discharged at day 2 or day 3, and that's an issue. And with the thulium, I can say never, but I almost never use the coagulation of the electrocautery after the surgery. And I think that with that, we reduce the irritative problems. And so it's an interesting technique for that, and an interesting length wave. And what you have to know too, that even if it's probably a little bit more difficult to do the enucleation at the beginning, you can do plenty of things with the thulium. You can treat your bladder tumors, you can treat your upper urinary tract tumors, you can open the stenosis very well. So I think it's really difficult now in an operative theater not to have a thulium inside your theater, because it's very, very useful for a lot of things. And that's an issue.
How good is this laser for stones?
What?
How good for stones?
Yeah, you can do the stone with it. So, for example, if you have a ThuLEP, you will be a little bit more difficult than the holmium to do the enucleation of prostate, but you will do plenty of things with that. And believe me, for stone, it's amazing. For incision, for upper urinary tract, it's amazing. I almost do all my low-grade tumor of upper urinary tract with the thulium now. No more nephroureterectomy or robotic surgery for this guy, with excellent results. And for bladder tumor, it's possible to do one-day surgery with that. So it's definitely quite interesting.
Just a question. Suppose that I'm a very rich surgeon and that I'm going to buy a new laser, and I'm very interested in thulium. What do you suggest? A standard thulium laser, or the so-called super thulium laser?
No, I'm probably going to buy a super thulium, because with that, you're going to do stones very nicely. Because
do you
stones,
think it's as effective as a standard thulium?
Super thulium with stones, it's incredible. It's incredible because there is no residual stones after the surgery. So that's the big issue with the holmium. You always have residual fragments on the CT scan, and it will be not the case if you do it with a super thulium. So for flexible rhinoscopy, it's a great advantage. So I will try to develop a little bit more the posterior plan. What I have to check, yes?
Jean-Baptiste, and what about the strictures after the procedure? Do you see any difference in the strictures rate between the different energy sources? It's about the size of the scope. It's about
Yeah.
the time of the procedure. It's about the blunt dissection and the movements you do in the urethra. So how this affect the strictures rate after the procedure?
About urethral strictures? Urethral strictures?
Yes, urethral strictures
Yeah.
after the procedure.
To be honest, I think that it's not problem of the laser or time of enucleation. I think it's a problem with the resectoscope. That's a problem of the sheath of the resectoscope. So I think that for Wolf, you have to use 24. For Storz, the resectoscope is very smooth. So there is no problem with urethral stricture generally. So of course, as for this patient, you have to do an urethrotomy if your urethra is too narrow to avoid any ischemia during the surgery. But generally, it was a problem at the beginning because we were working with the Wolf 26 resectoscope. We had a lot of strictures. Now we don't have anymore. So it's not a big issue. And I don't think it's a question of the laser. It's a question of the resectoscope. But now the industry have worked on that. And I think that with Wolf or with Storz now we have pretty good results about that. So I will do a proper incision of the lateral plane to try to find the correct posterior plane. I think that I had difficulties at the beginning because I tried to find the posterior plane of the adenoma from the apex. And I don't think it's a good way to reach it because you have 2 or 3 planes there, and it's very, very easy to be in the wrong plane. So now I try to find the plane from the lateral approach. So I cut and I develop a lot this plane. And with this, generally, when I convert and when I switch to the posterior plane, I have the right one. So as Fernando told you, it's very important to curve during your dissection. So you adapt the laser. You see, as you can see here, there is fatty tissue. So I have to be closer to the adenoma. Again, it's really easy to go outside. It's not a big issue for post-operative follow-up and results, but you have to be careful during your dissection with that. As you can see, it's a laser concutter. You have to accept that it's difficult to have exactly the same aspect during thulium dissection and holmium dissection. It's like that. But the results have been published and they are quite good. And to be honest, it's a feeling I have.
Have you any complaints about sexual dysfunction after with the use of ThuLEP?
So exposure needs to be very good at this part because at the posterior plane, generally the capsule is very thin because the prostatic adenoma pull on the capsule and makes it very, very thin at this part. So we have to be very careful with that if we want to avoid bleeding, because generally bleeding is coming from mucosa or disrupture in the capsule.
Jean-Baptiste?
Yeah.
Do you hear me? Do you have any complaints about sexual dysfunction when you use thulium?
I'm sorry.
Do you have complaints about
Erectile
sexual
function problems? No.
erectile dysfunction?
No. No, we don't have that, honestly. I have to say to the patient that psychologically it's possible to have a problem with erectile function, but generally in the holmium or with the thulium, the length weights and the deliverance of the energy to the tissue is very superficial, so it's not an issue. It's you have to know that it's just 0.2 millimeters the energy. That's all. So let's see if it's possible to switch a little bit the adenoma. It's not so bad. No, erectile function is definitely not the issue. The issue is the ejaculation. And I think that's going to be interesting to compare the technique of ejaculation sparing and aquablation, rhythm. And I think that the real challenge for laser will be that new techniques who can give you a proper result with a good disobstruction, keeping the ejaculation. The real challenger will be probably rhythm or aquabeam therapy or aquablation. Okay. So it's done. Probably we have a small nodule right here. So it's possible to vaporize it a little bit. Okay, we're gonna do the hemostasis. So as you can see, there is not a lot of adenoma inside the patient anymore, even if the plan is a little bit different. So I will reduce the flow of the irrigation to see what is bleeding. But generally with the thulium, there is not a lot of additional coagulation that you need after your enucleation. And as you can say, as I told you, it's very it's exceptional that I need to take the electrocautery after the surgery, as I do in holmium surgery. So this is continuous wave, continuous emission, sorry. So it's like this that we have the best hemostatic effect. And I think it's a real problem at the moment, because I think that I try to have the proper equipment in St. Augustine, and it's difficult to buy different laser. But I can say that it's going to be mandatory to have a thulium laser in your operative theater. I know it's difficult, I know it's very expensive, but how useful it is, it's incredible.
So, do you believe that in an ideal world you will do the enucleation with HoLEP, and after that we will change to thulium for the hemostasis?
Une fois qu'on va faire l'énucléation à l'holmium, on va changer au thulium pour hémostase.
It could be an idea. It could be an idea. I think that at the moment there is no perfect laser on the market. What I can say is that, to be perfectly honest, it's not difficult to do an enucleation of prostate with the thulium if it's not too big. If you have a prostate till 140 grams, it's okay. Above, to be honest, I prefer holmium, because the ability of enucleation is probably a little bit better. But if you want to do to 100 grams or 120 grams, thulium is working well with excellent results. But you know, when I operate thulium, generally it's Friday, and I'm always very confident in the fact that the patient will be discharged the day after. For holmium, it's not always the case. Okay, so we reduce the flow again, because it's very important for you to begin your morcellation in very good condition of vision. And it's mandatory to come back and do the coagulation before the morcellation if you don't have a proper vision. Okay, so we're going to go to morcellation. Thank you. It's okay.
So which morcellator are you going to use?
So morcellator is a Storz morcellator. I like it because it's very solid. We had some problem with the valve system in St. Augustine because you have to know that we are plenty of surgeons, and it was so fragile that after 1 month everything was broken. And because you have to know that we had beginners for enucleation, we have people who were working with Storz before, we had plenty of surgeons inside we are 9 surgeons, so we have a lot of different surgeons, and it was too fragile, and we had a problem because all our device for laparoscopy and cystoscopy were Storz, and it's not possible to adapt the Storz optic on the valve device. So we had one valve device, and when the optic was broken, or just after, it was all the enucleation technique was blocked for perhaps 2 months, and that's the reason why we decided to switch to Storz. So Storz is quite solid. We have not a lot of problem with that. Probably it works a little bit slower, but to lose 2 minutes or 4 minutes, can you go up to 1,800? And to lose perhaps 10 minutes or 5 minutes, but to be sure that you're going to have some proper possibilities to do all your enucleation during the week for you and your partners. It's quite interesting. As I told to Andrea, I think it's very interesting to have a look on the Neptune system, which is a striker system. It's not for the surgeons, it's for the nurse. And we have this in St. Augustine now for probably 2 months, and it works very well. You're going to take all the fluid of the suction during the enucleation and manage it. So it has its own pump to suck the liquid, and it's totally possible to make more than 100 liters inside, and so you never stop during your morcellation. You should have a look on that. It's very interesting for the nurse. So always I try to go inside the prostate fossa to do the morcellation, to block the adenoma during the morcellation. Here it's not very hard adenoma, so it's not a big issue. So we have here very non-tanum, 1 centimeter above, to try to keep ejaculation. I will check the bladder to be sure that there is nothing inside. Okay. Check the clots we can have inside the prostatic fossa. I think perhaps there is something here. So we'll cut the irrigation, use only the pedal for suction. And that's all.
Your comment with the use of these tools. In my experience, I had many accidents with the morcellator, more than I should, but I never had any serious complication for the patient with that. So it's important to be careful, but is it a tool that should be the new urologist afraid of? What do you think? Your comment, please.
What is interesting with at the moment with the thulium is all the paper is going out and published.
I was asking that if the accidents that happens during the morcellation are serious complications for the patient or not, usually.
So as you can see, I don't know if you... Yeah. Comment je manage ça? It's okay. So as you can see, it's crystal clear, and it's usually like that. So accident with the morcellation, I think that you're going to have accident with the morcellation if you have not a good condition of vision during your morcellation, first. And second, if your nurse or all the staff are not well trained to do this. One of the problem could be that the water stopped because the nurse didn't change the bags of water properly. The accident can happen if you have bad quality of vision and take the bladder wall. To be honest, we had some small perforation and a small lesion of the mucosa during the initial part of our activity. The initial part of our activity. But now I think it's okay because we have pump, we have the Neptune system, we have a pump of suction, the black one that we have here. It's the Storz pump who can suck very properly the liquid to have a good aspiration. And if you have a good aspiration, you have a good suction, you're going to have all the time the adenoma block in the mouth of the morcellator, and so you suck just a little bit of liquid. And we have we were working with a Storz pump too to water in cum. So we are always on pressure. It's possible to have a roller pump. You can generally I set it to 50 millimeters of water, and with that I'm sure that I have always the good pressure and the good inflation of the bladder during the morcellation. And for the injuries, the only we had was some small mucosa injuries, which is a problem because it bleed a little bit and need a proper electrocoagulation after. But to be honest, it's not a big issue if you are well trained, if your nurse are well trained, and if you have the proper device.
So you never had a major complication with the morcellation? A complication that cause the patient to stay more days in the hospital or something like that?
With the bladder injury during the morcellation? No, generally not. If you coagulate properly your bladder, it's not a problem. Of course, if you have done a big hole in the bladder wall, it's going to be a problem. But for me, it's not normal to have that kind of complication. It's possible to take a little bit the mucosa with a big prostate when it's bleed a little bit. But if you have a big injury of your bladder wall, the reason is that your coagulation of your prostatic fossa is not correct. And if the coagulation is not correct, you don't have to begin your morcellation. You have to stop. You have to take back your electrocautery or your laser and be sure that when you reduce the intake, the income of the water, there is no important bleeding that makes that your vision is not clear. You have to understand that when you do the morcellation, you reduce the water income of 70%. So you have only 30% of your irrigation fluid during the morcellation. And that's the reason why you need to see better you have to see better at the end of your enucleation that it was during your enucleation that it was during the enucleation, because of the reduction of this irrigation. So be very careful at the end of the surgery to do a proper coagulation, and with that, I think that you're going to avoid any complication with the morcellation. And of course, you have to take your nurse and go to an expat center to see how these things works, or perhaps work with the industry to tell people how it works, and have the proper device of water income and water outcome.
So, Jean-Baptiste, some questions. First of all, when are you going to remove the catheter from this patient? One. And what kind of instructions are you going to give to him?
As you can see,
what he has to expect the first weeks in terms of symptoms.
So, probably, as you can see, with the thulium, it's hemostasis. It is generally not a problem. So you can remove the catheter, I think, the day after without any problem. Okay. What I expect, it's generally that the result is pretty good. That irritative symptom is less than 5%. Stress urinary incontinence is less than 2%. And generally, if you have irritative symptom, these irritative symptoms are going to come for 3 weeks, because the cicatrization of the prostatic fossa go very fast because of the physical characteristic of the laser. So generally, more than 80% of my patients are discharged the day after. I have to be honest, I think that, for example, for this patient, it will be possible to be discharged this afternoon. So it depends a lot of things. When you discharge a patient the day after, you are sure that during the night you won't have a small clot or something, or pain or something that the patient is going to call you first. Second, you need to have at home, you need to have a specific urological nurse at home, because remove a bladder catheter after an enucleation, it's not very, it's quite specific. The way I use it, generally the nurse is going to deflate the balloon. Then she tracked a little bit the bladder catheter. She washed the prostatic fossa and removed all the clots. And then after, she put 200 milliliters of liquid inside the bladder of the patient. And like that, he will void immediately. And to have a nurse who can do this at home, it's quite difficult. We don't have that in France. There's that kind of specific free nurse downtown. And so that's the reason why I keep the patient one night. And to be honest, we don't have any emergency unit in St. Augustine. So if you have 3 or 4 enucleation a day and they call you all the nights along with the schedule of the program of the surgical activities the day after, it's not possible. So that's the reason why we keep them one night. And generally, I don't see the patient before 3 months. I see them if they have a problem. But generally, I ask a PSA, I ask for ultrasonography, generally 3 months after, and check if there is any problem. And if the patient is not comfortable after the enucleation, he can call me, of course, 1 week or 2 weeks after. But so that's generally how it works. And so it's of course, enucleation for this is very comfortable because you discharge the patient the day after and you reduce the occupation of your clinic. And so like this, you can reduce the number of nurses, reduce the number of beds. I think I will never switch back to TRP because in my activity, it changed a lot of things for me and for the department when we began that. At the beginning at St. Augustine, I was the only surgeon who was doing enucleation, and now we are 6. So almost all the procedures now for BPH are done by laser enucleation, thulium or holmium. I think that all that thing, all that stuff, we see how we come from where we come from. It was more or less 10 years ago we began the enucleation after Fernando in Bulgaria, and it changed a lot our practice. But what changed a lot is the material, the stuff. At the beginning, there were no resectoscope, no pump, no proper laser. It was really difficult to begin this activity. But I think that industry will be there more and more. And with the time, thulium, holmium, green light, we're going to find, I think, the best laser to do it properly. It's important to work on that with the experts. But for the beginners, what is important is to learn the good technique. How you have to manage your resectoscope, how you have to manage your apex, how you have to manage your morcellation. I think don't forget that the medical device, it's important, but the surgical technique, I think, is the most important thing that you have to learn. And after, with the experts, with the industry, you're going to have proper stuff. I see what it was 10 years ago, and I see what it is now. Everything has changed. So it's going to be more and more effective with the time.
Just for the organization, we're really in advance, so this is very it's fine. We will profit for the next hour if you have questions, and we will discuss at the room upstairs. Profit to ask questions to Dr. Gomez Sancha, because we will dismiss him in the afternoon, and we're coming with Jean-Baptiste in 2 minutes at the conference room, and we will start the third operation at 1 o'clock and not 2 o'clock, because we are really in advance. Okay, see you upstairs.
So thank you very much, and a big applause from us. Thank you.